Hi, my name's Tracy. I'm from the Gold Coast. I'm just got a question for Neti. Is that how I pronounce it? Yeah. It's around the feasibility and cost effectiveness. How you came up with 3 visits and why that was deemed the appropriate number. And do you have a systematic approach to how you get the outcomes you need from those 3 visits? And then how do you know that the patients don't slip into the old ways once those visits finish?
Okay, lots of questions. The 3 visits, in Indonesia we have standards for home visit, which is 4 visits. And then after we do some review, and then we can put it down into 3 visits because the first visit has been done in the community health center. So that's for the first one. And then for the outcome measure for each weeks. So we have 4 sets of intervention. So 4 sets of health education, 4 sets of what patient needs to do. For example, in the first week, we will explain about the importance of following medication. So they use the right dose, they take the medicine at the right time, etc. So and in the second week, before we start another module, we call it module, we will evaluate whether the patient really take their medicines in the correct way and etc. And then after that, if the patient has followed the medication, and then for the second week we will give information about dietary, so how to reduce, because Indonesian people like salt fish. It's kind of problem. So we try to explain and motivate patient to reduce the salty fish. And then the following week we will evaluate that. And then after that we will explain about how to manage stress management, and then we will evaluate it in the following week. And the final week we will recap from the first and second to make sure that they will do all what we have explained correctly after the intervention. Yeah, hopefully that's all. Yeah, the cost, yeah. Well, to tell the truth, I haven't measured the cost yet, but yeah, thank you. I think it's really important for the next research.
Okay, thank you. So I know there were some other questions. Yes, here. This lady here.
Thank you. Thank you for those inspiring pieces of work. I've always been interested in the notion since the days of Professor Kate Lorig on self-management, and the idea of the fact that we've got a self-care alliance in function out here, looking to do some work. And I'd be really keen to know if any of your work has involved to date the work of a health economist, because these projects need to be sustainable, and it's possible that a good argument about the health economics for everybody involved would be very useful. Do you think that's likely to happen in the next tranche of your research?
The simple answer for us is no, we haven't. I guess we've been looking at program costs of the previous externally provided program to the current internally provided program. There's little difference in cost, but we're obviously achieving much better outcomes. So we're getting much better return on investment from the outlay and cost. But in terms of true health economics, no, we haven't completed any of that yet. And it's a good point. It could form part of our future phases over the next few years.
Yeah, I was particularly, can I have another go? Be greedy?
Yes.
I was particularly interested in your work on the osteoarthritis program, because previously I'd seen it done and it was economically modelled, but it was only done in one hospital. That yours has got much broader ramifications if it's done well.
Yes, and ours is even broader than just our local health district. So we are funding this through part of the New South Wales Health Leading Better Value Care initiatives, which are being evaluated centrally as well. And so each health service is provided with guidelines and funding and targets, but actually how we implement it can vary from health service to health service. But overall, the Ministry of Health will then be conducting the analysis, and they're the ones who will be undertaking an economic analysis rather than us doing it locally.
Yeah. As long as it's not going to be a brilliant program left in a drawer.
Yes.
I'd just like to comment. I mean, I loved all these. First, to acknowledge Kate Lorig. She was sort of the professor that really laid the foundation for my interest in self-management. So for those of you who don't know of her work, one of her basic hypotheses in the beginning was the chronic illnesses are so prevalent, we can't do it through the healthcare system, that we must train lay leaders in order to have the groups, in order to marshal that along. So we take the best of what we're doing here and then know how do we, teach others. The second is in the economics of that program. If you look at the bundled care initiatives, bundled care around a joint replacement is to pay for the care prior and after. But that's not the same as your population. So what you did with your population, you were really creating access to good care early on because they couldn't get into the orthopedist. But what you also did is you reduced a tremendous number of surgeries, and certainly the economic model needs to look at that at the population level.
Absolutely. And one of the issues that we found when we started this work, and we started before the New South Wales Health announced their Leading Better Value Care initiatives, was this is something that we wanted to do, and we approached the managers, and one of the managers gave me the response of, Chris, you don't understand, I don't get paid for surgery that we don't do. The funding drives what we do. We need to put the funding in the right places to get the outcomes we want.
Absolutely true, still true in the States, and it is only under true value-based payment systems that we can actually then have a chance to not only measure it internally, but to scale it.
And for those who aren't familiar with Leading Better Value Care in New South Wales Health, please go and Google it. I'm sure there's similar things happening all over the world, but it is saying if we provide good care early, it's better both for the patient and the economy.
Absolutely. I mean, you don't need me to facilitate a discussion, do you? This is fascinating. Does anyone else want to join in the discussion and add something? So we'll have a question here and then over here. We'll start here. And I think these will be the last two questions.
Great, thank you. Thank you for a great presentation. Alexandra Klonin from the World Bank Country Office in Poland. There's actually an integrated care pilot project happening in Poland. It's quite big, and one of the aspects, the new elements of the program is the health checkups and identifying people who have risk of developing chronic conditions, and basically setting up a health self-management, health education plan for the patients. The World Bank is responsible for evaluation of the project, and so far what we're seeing is a scary number of people who started the program, so they had the health checkup, they started the plan, but on the third, the self-management health education visit, 99% of people didn't come, so didn't follow the whole process. So I'm just asking you from your experience, what is the solution to make sure that the patient follows the program of self-management and health education? Thank you.
Can I just, as chair, be cheeky and ask, were patients involved in designing the intervention?
No.
Okay. So
Yeah,
that might be
it's basically a pilot project, so
Yep.
this is what we're finding out now. It's still going to be happening for 2 more years, so this is a time to change things, so probably involving patients and consumers is one way to do it, but so far for the education they have to come to the clinic, so probably that's one of the obstacles as well, so they have to actively go and see the doctor or the health educator, even though they're like, in their eyes probably they're healthy, they just have the risk.
over the panel.
So, sorry, I'm not familiar with your project, so I'm just going to hypothesise. You said that it was for people who are at risk of chronic disease.
Yeah.
I think if you're at risk and you haven't developed the symptoms, you haven't developed the problem yet, your motivation to undertake lifestyle changes is much reduced. Sorry.
Yeah, I'd 100% agree with that. And I think definitely involving consumers in the aspect has been a big part of what we've been doing as well in designing our program as well as other programs. But I still feel, and it's interesting because part of the work we initially started to do was look at the quality of the coaching, and where we had reported numbers of coaching, that was self-reported. And when we actually looked at what that coaching was and how people were applying it, sometimes it was not coaching at all in our aspect. In our view, it was actually still being quite directive. It wasn't, goal focused. It wasn't solution focused. So although people were saying they were coaching, to what we believe coaching is, we didn't think they were. So I think that's something to be aware of too, that sometimes providers think or say they are coaching, but they might not be. And from our work with the consumers, we also found that every consumer said that follow-up on the original coaching session in terms of goals and plans, etc., was extremely important, perhaps vital, but only half our providers admitted to actually doing that. So, at the provider end, I don't think we're working hard enough to actually implement coaching skills, which would help with that, but then also they don't follow up on it when they do. So we need to change that.
Thank you.
I see time exceeded.
Time has exceeded, but we can...
Just two quick comments. One, I really don't believe in a doctor-centric model, even though I'm a physician, but there certainly is evidence that when providers, physicians, make positive statements in support of these programs, it makes a difference. So when they come in and trying to get the providers in support, just simple comments can be powerful. The second, I'll leave for further conversation, but I have a friend who's in education reform, and basically they changed their system from what I would describe, he described as teacher-centered, time-based, move through with your cohort. You get an A in this and an F in that, you still move ahead. 2, student-centered, performance-based. I think in healthcare, we need the same. Not provider, doctor-centered, treatment-based, but rather truly patient-centered, performance or outcome-focused. So if it has to start with the patient. So if those individuals don't perceive they have a problem and they're not in charge of their own learning, they won't follow up for the 4th or the 2nd.
Thank you. Look, I know we said we'd take another question, but time has got away from us. Our panellists will be around if you want to direct a question to them in the break. But this has been a fascinating presentation and 4 wonderful presentations and a great panel discussion. So if you could please join me in thanking all of our presenters. And keep the applause going for the wonderful questions and discussion, and let's continue the discussion over lunch. Thank you.